Before you prescribe your next sleep aid, there is something important that I want you to know. Most clinicians were never taught this in training, and even fewer were taught how to talk to patients about this. When you look at the evidence, the actual effect sizes of most sleep medications are far smaller than we were led to believe. Yet, our patients are suffering, and it's completely understandable that clinicians feel the pressure to do something to help them. Today, I'm going to walk you through a practical, clinically grounded framework for when sleep aids actually help, when they don't, and the exact dialogue that prevents dependence, misaligned expectations, and medication cycling. This is guidance that I wish every clinician received in training, and this question was actually brought up by a psychiatrist who's in my clinical sleep kit training program for clinicians, so I thought this would be a good topic to discuss. Let's start with what the evidence actually says, because it might surprise you. Most clinicians actually overestimate how well sleeping pills work, and it's not because anyone is doing anything wrong, but when the American Academy of Sleep Medicine reviewed the research, and this comes from the Journal Clinical Sleep Medicine paper, which I'll link below, the findings were remarkably consistent. The effect sizes of sleeping pills are small. Most hypnotics reduce sleep latency by only about 10 or 20 minutes, and wake after sleep onset by around 10 to 30 minutes, depending on the drug and the study. And almost all trials are short-term, many lasting only just a few weeks. And when it comes to daytime functioning, that was either not measured or minimally improved or inconsistent in improvement. This matters because patients want to feel better during the day, not just see a small change in how many minutes they're sleeping. Now, interestingly, there's no consistent guideline on how to use sleeping pills in practice. In May of 2016, the American College of Physicians published its own clinical practice guideline for the management of chronic insomnia. This guideline made two major recommendations. The first was that all patients with chronic insomnia should receive CBTI, or cognitive behavioral therapy for insomnia, as the initial treatment intervention. This was a strong recommendation based on moderate quality evidence. The second recommendation was that a shared decision-making approach should be employed by clinicians in determining whether pharmacotherapy should be employed for patients who did not achieve adequate response with CBTI. There was also insufficient evidence to determine the efficacy of benzodiazepines, trazodone, and melatonin in the management of chronic insomnia. Studies of more recent generation sleep aids, like benzodiazepine receptor agonists, doxepin, and suvorexant, found some improvement in sleep outcomes, but much of that evidence was of low quality. So why is there this mismatch between the data and expectations and clinical practice? Well, clinicians often overestimate efficacy due to four very real and understandable factors. One, training didn't emphasize CBTI. Most clinicians simply weren't taught how to use CBTI in their practice, or even what it is. CBTI is often conflated with sleep hygiene, even though they're not the same thing. Number two is that pharma narratives have shaped expectations, even indirectly. Number three is that patients often equate medication with solution. They expect rapid relief and hope that a medication will provide that, even though the data doesn't support that that's what actually happens. Number four, and this one is important, which is that as clinicians, we often feel the pressure to do something. Not in a careless way, but in that we've got 15 minutes, I have an exhausted patient, I have a long list of patients to see, let's do something to give them some relief. And prescribing often feels like the appropriate action. It feels like it is helpful. So how do we actually use this data wisely? Instead of thinking of sleep aids as curative or as a long-term solution, think of them as symptom stabilizers. What they can reliably do is they can help some patients fall asleep a little faster. They can reduce awakenings modestly. They might provide a short-term sense of relief. And they can create a small window where you can start addressing the actual underlying problem, which is usually a behavioral aspect, addressing those perpetuating factors that keep patients stuck in the cycle of insomnia. What sleeping pills don't do is they cannot fix chronic insomnia. They cannot retrain that conditioned arousal that keeps people stuck in the cycle of insomnia. They cannot restore the circadian rhythm. They don't actually improve daytime functioning in a meaningful, sustained way. And they can't treat other sleep disorders. So for example, if the patient actually has underlying obstructive sleep apnea that is presenting like insomnia, prescribing a sleep aid is not only not helpful, it can be dangerous. So when you hold this perspective and communicate it clearly to your patients, prescribing becomes more precise, safer, and less stressful for both you and your patient. So how do I actually use sleep aids in my practice? They do have a role, but only when we use them intentionally with boundaries and a clear exit plan. So I think think of them as helpful in 3 main clinical scenarios. Number 1 is short-term stabilization during time of acute stress. If someone's going through an intense period of stress, like a flare-up of anxiety, or maybe a loss of a job, or overwhelm with caregiving, sometimes a sleep aid can reduce the physiologic arousal just enough to get them through that difficult phase. So this is where one of my strongest boundaries comes in, which is that I rarely prescribe a sleep aid for more than 2 weeks at a time. 2 weeks creates enough space for stabilization without drifting into dependence or tolerance, or where this becomes now a long-term option. Scenario number 2 is for intermittent support for specific types of groups. This includes people who travel frequently, shift workers, or people with predictable other environmental disruptors where they might need some additional support on an intermittent basis. So the key concept here is using it intermittently, maybe for a couple nights here or there, 1 or 2 times a week, but not every single night. Now, here's a little clinical pearl that's important for informed consent if you are prescribing benzodiazepines. The American Society of Addiction Medicine's latest guidelines showed that benzodiazepine withdrawal can occur with use of 4 or more days a week for less than a month at any dose. So we need to be transparent about safety and avoid nightly use of benzodiazepines wherever possible. If you want a deeper dive into the guidelines around benzodiazepine use and deprescribing, I have a full tutorial with Dr. Harvinder Singh. He's a psychiatrist who walks us through the latest ASAM tapering guidance for benzodiazepines. You can check out that video. Now, another thing I do with every patient if I'm prescribing a sleep aid is to have the exit plan conversation before you even prescribe the medication. So this reduces nearly all downstream prescribing complications. What you share with the patient is, here's why we're using this medication. Here's how long we're going to use it for. These are the parameters for how to use it. This is how we'll check whether or not it's working for you. This is when we're going to stop, and this is how we're going to stop or taper the medication. So this clarity prevents the I just need another refill type of request, and it creates shared expectations, and it gets buy-in from the patient. And overall, it's about patient safety and providing them with the appropriate treatment for their sleep issue. If you want more support and education around sleep medicine, then get my free sleep mini course for clinicians. It goes deeper into the sleep medicine tools that you need for your practice. You can get that at intrabalance.com/doctors. Now, most of the challenges that clinicians face with sleeping pills come down to misaligned expectations. So let me walk you through the exact language that I use, plus the most common patient questions and objections. So the first thing is how you introduce the medication. Here's a script that you can save. This medication can help your sleep happen with a little bit more ease, maybe helping you fall asleep a few minutes faster or stay asleep a few minutes longer, but it does not fix the underlying issue that's driving your insomnia. So we'll use it as a temporary support while we work on retraining your sleep system. Number 2 is setting the duration boundary. So a script that you can use is, we'll use this for a short period of time, no more than about 2 weeks, and then we're going to reassess. This helps keep the medication effective without creating dependence or tolerance. Patients do appreciate that clarity and that expectation. The third thing is setting boundaries about rebound insomnia. So what you can tell patients is, I want you to know about something called rebound insomnia. This is when your sleep feels worse when you don't use the medication. It's a common side effect of sleeping pills, and we don't want you to get into a cycle where you cannot sleep without the sleeping pill. We're going to work on ways to retrain your sleep system so you can sleep better naturally and not have to rely on an external sleep aid. And then number 4 is addressing some common patient questions and how to respond to them. One of the questions I get a lot is this going to fix my sleep? So what you can tell patients is that it can help sleep happen a little bit more easily, but it doesn't fix the insomnia itself. That's why we're going to pair it with behavioral tools that can retrain your sleep system. Another question you might get is, can I take this every night? What you can say is that it's more effective and safer when it's used short term or just once in a while. Taking it every night can increase the risk of dependence. It can stop working as well over time, and it can cause rebound insomnia. So I don't recommend that you take it every single night. The third question you might get is, what if this doesn't work? And what you can respond with is, if it doesn't work, that's actually helpful information. It means that medication probably isn't the right tool for you. So we'll shift our focus to other things that create lasting change. We're going to figure out why you're stuck in this cycle of insomnia, and we'll shift our focus to addressing those root causes. I'd love to hear from you. What's the hardest part when it comes to talking to patients about sleeping pills? Is it setting boundaries? Is it handling their expectations? Is it getting refill requests or requests to change their medication because it's not working? Is it something else? Let me know in the comments below. I'd love to know what you're seeing in your practice. To recap, the evidence for sleeping pills is weak at best. They're most effective when used intentionally and for short-term support. And the patient conversation around expectations, boundaries, and safety determines success. When I'm using sleeping pills with patients, I usually recommend using them for no more than 2 or 3 times a week at most. We go over the situations where it might be useful, but we spend most of our time working on the behavioral, environmental, and medical factors that keep them stuck in that cycle of poor sleep. And those are the long-term strategies that actually create lasting success. Now you have a framework that you can use in your clinic tomorrow. If you want to keep building your sleep medicine knowledge, subscribe to this channel.